Myself and Wolf are going to do sort of a little double act. So I'm going to start with some very basic introduction of the, sort of the key terms and the key concepts. I'm going to give you a brief overview of why I think we need evidence of cost effectiveness. Tell you how it's done, but very briefly. I'm not going to go into the technical details because you probably aren't that interested in those bits. But what I am going to talk about are some of the key challenges. And the reason for raising them is not to be negative, but I always think that if you know what the problems are, then you can maybe think of a strategy or solution to address them. So that's my purpose for mentioning those. And Wolf is going to present you with an applied example of a model-based cost-effectiveness analysis. So hopefully, by the time you get to the end of our two talks, you'll have a nice overview on what it can offer you. So these three key words are very important to health economists: scarcity, choice, and opportunity cost. They underpin everything we do. Scarcity, because we're working in systems where there's a finite budget allocated to healthcare on an annual basis. Often throughout that year, people will decide to introduce new interventions into clinical practice. So decision makers who are allocating scarce healthcare resources have to make choices about which ones they think are best to invest in. And this idea of opportunity cost is reflected by this cartoon. Not very funny, but it gets the point across that if you have a fixed amount of time or a fixed budget and you decide to use that time or that budget in one way, then you're giving up the opportunity of doing something else, and you cannot accrue the benefits of that thing that you're giving up. So that's the rationale for opportunity cost, and it underpins our methods of economic evaluation. Now, just a short side comment here, in that economic evaluation has become the most famous toolkit that you'll see health economists talk about. It's by no means the only thing that we can do. Life would get very boring if all we did was economic evaluation. So don't think that all I do every day is sit doing this sort of work in my office. I'm a little bit more interesting than that. Not too much more, but a little bit. So what are economic evaluations? So you have some starting point, and this is where you're defining your decision problem. So this is the scope of your analysis. So you have some process of healthcare that you need to deliver. And there might be different alternatives that are available to you. So you could use a diagnostic test, or you could use no test in this particular example. Now, this is where this links very strongly back to this idea of opportunity cost, because it explains that you need to have some comparison there. So what else can I do with the money? What is my intervention, and what else could I do? So here we have just two comparisons. It can get a lot more complex than that. It also explains that you have to be very clear about what this process of healthcare means. And this is quite often the hardest part of the evaluation. And this is really where health economists really do value working in a multidisciplinary team, because we need to be able to understand what is it that we're trying to value within these evaluations. So then the first bit that you have to think about is, well, given you've got this process of healthcare, what are the inputs? So what are the resources required to actually deliver this process of healthcare? So it might be a new technology, it might be lab consumables or staff, or you might need training. And this is where you attach the cost side to the evaluation. So if things go well, these costs flow through the process of healthcare, and then you get some outputs. And this is where you start to define the different types of economic evaluation that you might have come across in the literature. So you could focus on measures of clinical effect. For example, you could look at the predictive value of a diagnostic test, and you would then do cost effectiveness analysis. You could also look at it in terms of what is the impact on health gain. So you look at quality adjusted life years. Well, what this means is you think how many extra years of life you get from your intervention, and you quality adjust them because you assume those extra years of life might not be perfect. For example, if you give someone chemotherapy, you might extend their life by 5 years, but they're not in the health state that they were in, that they would like to be, so they're not in perfect health. So you can adjust that, and that is what the concept of quality adjusted life year means. The other approach I've got on that slide is something called cost-benefit analysis. Now, this term is sometimes used inappropriately, but it has a very explicit meaning in which you use a method to attach a monetary value. So what are people's willingness to pay for a new intervention? Now, whatever method you use, there are two things that are really important to you. First thing is to define your study perspective, i.e., which costs are relevant and which outcomes are relevant. So I live in the UK. We tend to focus on how we best spend our healthcare budget, so we take a healthcare system perspective. That means you would not include the cost to the patient. Now, someone from the Netherlands might take a different view, and they might say, okay, we want to take a societal perspective for our evaluation, so they would include the cost to the patient. So depending where you live and the purpose and why you're using your economic evaluation will affect your perspective. And this is all defined by your decision problem. The other thing that's important is the time horizon. So how long do you follow people up for? So again, in the UK setting, if you look at recommendations from NICE, they say, let's assume a lifetime horizon. So follow people up from the time they had their intervention to the time that they die. Now, sometimes that's either not relevant or feasible. So if you're looking at the added value of a diagnostic test, is it feasible to follow somebody up from the time they had the test through to their entire lifetime? Perhaps not. But you have to again think about what is it that we're trying to do with our economic evaluation? What decision problem are we trying to answer? The other choice we have at this point is how we actually generate the evidence and structure the evidence in our analysis. So there are two main types of economic evaluation that you will see. Trial-based, in which you actually go out and prospectively collect new data. So this could be in a randomized controlled trial context, or it might be in an observational study type context. But the shorthand we tend to use is trial-based, implying it's new data that you're collecting. The other method is model-based analysis, and this is often perhaps more useful, and Wolf's presentation will explain why we tend to focus on using model-based analysis rather than trial-based analyses. And what this a model-based approach does is say, let's take our process of care, so you've got that in here, our little green arrow, and let's define that and the subsequent inputs required and outputs required as a decision analytic model, i.e., let's represent the decision problem and care pathways that we need to capture. And again, Wolf's example will make this more clear in your head. You need to see an example to actually see what that actually means in practice. So the last thing I want to say about this slide is we've got three alternative methods of using economic evaluation: cost effectiveness, cost utility, and cost benefit. These two, so cost effectiveness and cost utility analysis, will tend to be the ones that you'll see used in practice. And in a moment I'll explain a little bit why that is. The other thing to explain, just to make things more confusing, is whether you call it a cost effectiveness analysis or cost utility analysis, or interchange the two terms, depends on whether you are British or, on the other side of the pond, North American. So North Americans tend to make a very explicit difference between cost effectiveness analysis and cost utility analysis. And usually for the British, who are very careful about their use of language, we actually interchange the two terms, and we will call cost utility analysis cost effectiveness analysis. And that's because the framework or the methods that underpin the two approaches are very similar. Cost-benefit is a whole new world. It has a different theoretical underpinning, and in the UK, we tend not to use it. Now, when we come to our question and answer session, if you want, I can explain why. So, in the UK, we use cost-effectiveness analysis. And the most famous body that you will have probably all come across now that uses cost-effectiveness analysis is the National Institute for Health and Care Excellence, or NICE. Now, NICE is often viewed as this homogeneous decision-making body. That's not at all true. It has an extensive number of different sub-programs and sub-focuses. I've listed 4 examples there. We've got technology appraisal, diagnostic assessment, clinical guidelines, public health, but there's more. And so NICE has its own basic approach to using cost-effectiveness analysis, but there are nuances. So if you look at public health, they take a slightly different approach to the one that they take for technology appraisal and diagnostic assessment. But the basic approach is that you need to generate some overview of what is the relevant evidence base out there. So a health technology assessment report is produced. And that will be defined by the scope of the appraisal. So you'll have what is the technology we're looking at, what are the comparators, what are the patient population. And that's all in line with your study perspective and time horizon. Then you'll go out and say, okay, within this report, let's collate all the relevant clinical evidence and economic evidence. And when you start to look at this economic evidence, NICE has published this useful little toolkit, if you like, and they've called it a reference case. Now, the toolkit is called the Methods Guide for Technology Appraisal, but it's actually, it can be applied to all the different NICE programs. It's called a reference case because it's not a guideline per se. What NICE would like is if you can stick to the recommendations within this reference case, but if you see a good reason why you don't want to stick to those recommendations, just give a really good reason and then we'll think about it. Now, there I've got some key things that are listed in terms of what the NICE reference case say you should consider. So I've already alluded to the fact they'd like you to take a lifetime horizon. They'd like you to use model-based cost-effectiveness analysis. They'd like you to take the health system perspective for resource use and costs, and you should focus on valuing health gain, i.e. what's the health benefit for these interventions. And it's health because we're spending a healthcare budget. Now, in a moment, you'll see why that's so important when we start to look at how to do cost-effectiveness analysis of genomic-based diagnostic tests. More specifically than that, NICE also says we need to use this special measure of health called the EQ5D. All that is a very simple, short, standardised questionnaire that measures health status. It has 5 domains, 5D, and its EQ is Euro-Qual. It was developed for use in Europe, quality of life. So that's what that little acronym stands for. And we use that to generate our quality-adjusted life years, to capture the benefits of interventions. Now, I've spent quite a lot of time on this slide and explained all about it, and then I'm going to completely dismiss it by saying, well, when we look at genomic-based diagnostic tests, NICE is not interested. So why are we talking about this? So NICE is becoming more interested. I think that this is why it's going to get more important. So at the moment in the UK, it's the remit of the UK Genetic Testing Network to produce the evidence base to support the introduction of new genetic tests. But NICE is getting a little bit more interested. There have been some examples where they've started to look at genomic-based tests in some detail. So as part of the Diagnostics Assessment Programme, they've looked at EGFR mutation testing. Now, they're not genomic-based diagnostics for rare diseases, but they're getting more interested in the genomic applications. As part of the Technology Appraisal Programme, they've also started to look at examples of stratified approaches, so using companion diagnostics. But specifically, they don't look at how we should introduce genomic-based diagnostic tests into clinical practice. And at the end of this presentation, you will hopefully see why it's too hard. Right, now I was told to put little multiple choice questions in. Is that right, Francesca? Yes? Right, so have you been listening? So, what is the definition of a cost-effectiveness analysis? You've got option A, B or C. I'll give you a few minutes to read it. If you want to participate, you can choose your option. I'm not going to expect a show of hands. I'm not embarrassing people. All right? Are you ready? I'm going to give you the answer. I'm interested how many people got it right. Anyone? Wolf didn't. Oh, some people did, okay. That was just to check that you were listening. So I'm going to focus now a little bit more on genomic-based diagnostic testing. Now, I am not going to say very much about this. We have a phrase in the UK, teaching your granny to suck eggs. That means telling a highly educated audience something they already know. So I'm not going to spend very much time on this. But I do want to lay out some of the key issues. So I've started to use the phrase genomics, but if you look at clinical practice, I don't think I'm wrong in saying that the majority of tests still are genetic-based tests, in that you're looking at single genes to diagnose a rare disorder. But we are now starting to see some exciting examples, and looking at the programme, I've seen there are some applications of using next-generation sequencing. So you've got gene panel tests for inherited eye disorders. You've got some applications of using whole genome sequencing, and of course we've got the 100,000 Genome Project in the UK, which is pushing all this forward. Now, why is this important? Moving from looking at single genes to multiple genes poses us with some challenges. If you look at published economic evaluations, they focus very much on a single technology and a single gene. In a moment, you'll see why moving to this genomic approach makes life a little bit harder for us. That's not saying that what we've done in the past has been sufficient either. So I don't think we've done a very good job at doing existing economic evaluations. So we're starting from a very low place, and then and then it's getting very, very hard. So let's see how we get on with actually producing something that's useful for decision making. So the other thing I wanted to mention, which is very important, is we've tended to view and use the language very poorly when we distinguish between a technology and a diagnostic test and a service, because they are all different. So the technology might be next generation sequencing. That is not your diagnostic test. Somebody has to go out and produce a diagnostic test from that sequencing technology. And then, as this slide will show you, that has to become embedded in a model of service delivery. So you have to think of a way of your patient or patients or family members presenting to the clinic, thinking about the current model of service delivery. How does your new genomic test fit within that pathway of care? Because the associated counselling and referral to family members is all going to affect your relevant study population, how you define your intervention, how you think about your resource use, and how you capture the benefits. So this is all viewing, looking at the use of genomic-based diagnostics in the context of it being a complex intervention. Now, I don't know if many of you are aware of quite an important framework that we have in the UK setting that was developed by the Medical Research Council. So what they did was have produce a framework in which you should follow when you're trying to evaluate complex interventions, defined as interventions that have several interacting components. And I think if you think about how you were just looking at where a genomic-based diagnostic would fit into a model of service delivery, that is a complex intervention. And there are associated handbooks now that are also being published that are talking about some of the technical and methods challenges that will appear when you start to try and evaluate these complex interventions. So what becomes hard? It becomes hard to define the relevant patient population. If you think about the example of clinical genetics, is your relevant patient population your proband, or is it your family unit? That is not a small problem to solve, and it will affect what types of resources you include and the benefits to whom should be measured. You need a clear description of the intervention and the comparators and the subsequent treatments and care pathways. The intervention, you think, well, that's easy, it's just the test. Well, it might be, but is that the test using Sanger sequencing or next generation sequencing? Does that make a difference? Who knows? The comparators, you'll see in a moment we've got quite a scary slide that shows when you start to look at more than one gene at once, how the numbers of comparators that you need to include explodes dramatically. Subsequent treatments. Patients in genetics might not be treated in the sense of giving them a medicine, but they might get some management options. So this, again, is a complicated issue that you need to think about. And then the two bottom bullet points there really flow from these two original points on the slide. So how do you collect the appropriate resource use data, and how do you measure the patient benefits? Remembering when we're doing an economic evaluation, we've got that two-sided approach. You've got the inputs and the outputs. So, this is where I start to sound a little bit negative, but I don't apologise for that. I just want to lay out what some of the challenges are. And I've defined these challenges under 4 headings: technical, practical, organisational, and methodological. Technical. And again, just alluding to Wolf's presentation, he will show you some of the technical challenges they had when they designed their own model-based cost-effectiveness analysis, what sort of thought processes they had to go through when they moved from that nice little simple model of inputs and outputs to actually creating a model that represented reality in a good enough way. So I use this slide. I'm not sure if there's anyone in the audience who's a member of, don't see anyone. No TechGene members here, are there? No. So I was involved with a European Framework 7 funded project called TechGene. And the goal of TechGene was to develop applications of next generation sequencing, looking at different examples of conditions. One of the targeted areas was the diagnosis of inherited ataxias. And what they wanted the economists to do was to produce some model-based analyses to show the benefits of next generation sequencing. So what this slide shows you is the challenge we had when we had to think about, well, what are the relevant comparators? So this is a technical challenge. So when you're building a model, you have to say, well, what is the current standard of care? So, okay, let's go to some nice guidelines. And this is the recommended patient diagnostic pathway. You've got the presenting primary care. I should have counted these beforehand. We've got 10 different tests there. Secondary care, first line tests, another 10. Second line tests, blimey, lots. Okay, and then they go on to have their genetic screen basic, or if that didn't come back with anything useful, they have the second screen of genetic tests. Now, how do you define a standard care pathway from that? Inherited ataxias are heterogeneous. You haven't just got one pathway that every patient follows. So that is our first problem. It's a technical problem, and it's solvable, but we've got to get our heads around that. So you have to have some quite careful conversations with experts in neurology, genetics, and the lab people. So what we decided to do was highly simplify this into something called a discrete event simulation. So we turned it into a series of discrete events that represented a simulated patient timeline. And you can see we've got two branches there. So current Sanger sequencing, and then what would happen if we use this new panel. So basically, what this shows is that introducing this new panel moved the genetic diagnosis to the front of the care pathway rather than the end. That's very important. But it also allowed us to say, okay, let's cut out all the noise and let's think about what is it that we need to do when we're trying to diagnose someone with using a Sanger sequencing test. So these models are useful, but they can only be as useful as the technical ability of the model that you're using. Second problem we've listed was practical. And this is something that is not new, and it's something that health economists always moan about. And I think Wolf might touch on this, and that's the availability of data to populate our models. Because as with anything, rubbish in means rubbish out. So if the data aren't very good, doesn't matter how technically good your model structure is, you're not going to get a useful answer for decision making. And there's going to be extensive uncertainty around your answer. So what's the challenge with genomic-based diagnostic tests? The challenge is how they are regulated or not regulated. Because if this was something like a medicine, we have a very strong randomized control trial evidence base that is there to actually introduce the medicine into clinical practice. That doesn't tend to exist for genomic-based diagnostics. And layered on top of that is the challenge between looking at the technology and the test. So when you say evidence-based for what? The more simple answer, when you're looking at a practical challenge, is having a national pricing tariff. So a medicine, you can go to in the UK, British National Formulary, it'll tell you this is the unit cost for this medicine. We often don't have that for a genomic-based diagnostic test. So if you're trying to do your economic evaluation, you haven't even got the cost of your test, and we have to divert a substantial amount of effort doing micro-costing studies to try and get that unit cost before we can go any further. Organisational. This, I think, is the trickiest problem that we have. What I mean by this is the context in which you're doing these economic evaluations. Now, this is a nice, simple model of our NHS. It's not. The NHS is not a simple organisation, and we are trying to produce economic evidence in a context in which you have silo budgets, and the people who might realise cost savings might not be the people who see the gains. So that is a problem, because if you're trying to convince someone to introduce a new test into clinical practice, you've got to have evidence that's going to persuade them that it's a good thing for them. And yet we're saying, well, let's just take the health system perspective. Often that doesn't persuade your service commissioner. I don't have any solutions to this, by the way, unless we have different governments or different ways of setting up our budgets. But this is a substantial problem for us, not only in the UK, but in Germany, the Netherlands, wherever, because these two people often don't want to talk to each other. So you've got your specialised services, your specialised service commissioners for genetics, and then you've got your secondary care people. If you're looking at moving between the two, they don't want to give up their budget. So the last point is I'd like to talk about is methodological. And I've just picked on one example. If you look at this paper and many others, I only picked this because I was on it. There are many papers that have talked about the methodological challenges, looking at personalised medicine, the phrase we used here, because we were told to, genomic medicine. So in this paper, we suggested there were 10 challenges. On reflection, we called them methodological challenges, but I think some of them were practical and some of them were technical, not all methodological. If you think about the key methodological problems, these are the ones that I think are the most important. Are we correct to use cost-effectiveness analysis, or should we use cost-benefit analysis? And you'll see in a moment why that's quite an important question. How do we define this relevant study perspective? Are we correct to still focus on the healthcare system? The potential for infinite time horizons. By this I mean, if you look at, if you define a genetic condition in a family, you're then saying, okay, this could affect future generations, not just the generation I'm looking at. How do you capture the spillover or knock-on consequences of a diagnosis in one person compared with the family member? And the last one, which is the one I'm going to focus on very quickly now, is how do we capture the benefits of a genomic-based diagnostic? So this paper was, so genomics was hidden in this paper on purpose. So when I wrote this in 2013, health economists weren't that interested in publishing stuff about genomics, so I hid it behind talking about complex interventions, so we got it into a health economics journal. I'm not sure if it's any different now, but the basic premise of this paper was this. We know that patients who come and use clinical genetic services are generally healthy, but they're at risk of developing or transmitting a condition. Often there are no treatment options. This may mean that if you're looking at how to capture the benefits, it might not be the traditional health gains that we're used to as health economists. We might not be able to use our quality adjusted life year. But we do know, and people in the audience know, that patients and family members do value getting a genomic-based diagnostic. They value the information from that test. But most economic evaluations are currently using quality adjusted life years. Are they measuring the right thing? So this was the premise behind that paper. Again, just a quick check. What is a quality adjusted life year? Give you a minute to check you're still awake. I can see a few of you not, but I don't blame you. It is quite late. You got an answer? How many people were right? Oh, better. Oh, well done. So, just to remind you, the aim of this paper. So we're looking at, is health status the appropriate and only measure we should use when we're looking at the value of a genomic-based diagnostic? And if it isn't, what's NICE going to do? Because at the moment, NICE says that should be the only relevant measure of health status. So how can we look at a genomic-based diagnostic test in the context of NICE appraisal programs? So what's the right phrase? Why use one method when four will do? Okay, so we kind of took, I think the NICE phrase is a mixed methods approach. We just threw as many methods at this problem as that we could possibly think of. Is perhaps a more accurate way of describing what we did. So we started off with a systematic review and looked at how many measures are out there to look at the value of a clinical genetics service. At the time we found 67. We asked patients and representatives and healthcare professionals, out of those measures, which ones they thought were the most useful to them. So we did that using a Delphi panel. So they had time to think about their answers. They had a 2-round Delphi panel. We tried to do focus groups to ask them what they thought the main goal of a clinical genetics service was. I say try because they failed, because what we achieved was getting people meeting other people with rare genetic conditions. So, oh, I never met one of you before. So they all had a very nice time chatting to each other, but they didn't help our research. So we stuck them in a room on their own, so they couldn't talk to anyone, and interviewed them. And that did work a little bit better. And then we had to think about how do we bring it all together. So we triangulated all that. And this is what we found. So this work reflects a lot of the work of my colleague, Marion McAllister, and a lot of you in the audience I know will be aware of this. So we basically defined the overarching remit of a genetics service as information provision and said, okay, we've got these process attributes that are important to people. Process because they're the process of service delivery, having time to talk, having a service that's accessible and local, thinking about the relationship with the genetic counsellor, being able to have open access or yearly follow-up, whichever suits best. So these are all process attributes that contribute to outcome. And outcome was again defined in a complex way, so it was multi-dimensional. But within there, you can see this idea of having information about the knowledge of the condition, having an accurate diagnosis, helping them to cope. And I've added this phrase, capability to make an informed decision. So are they able to use all that information within their family unit to go out there and function in a cognitive and capable way? So Marion called this empowerment. I prefer the phrase capability. What is missing from that slide? Nobody said anything about health status. So that was great for Marion because she could go and design her new measure of empowerment. Rubbish for me because that's all health economists can measure. So we were a bit stuck. So what do we do? What should we do? Because in the UK, we're very focused on saying that if you're spending a healthcare budget, you should be maximising health status. But we've had some good empirical evidence to suggest that that's not what people were valuing when they were using the service. So what are the options open to us? Now, we have some help, if you like, because there is sometimes a view that genetics is exceptional in some way, but there are very close synergies and analogies that you can make with other areas, and the most obvious one is public health. Wide study perspective, again relevant. Long time horizons, difficulty focusing on health, limited non-RCT evidence. They suggest using something called cost consequences analysis, so taking those multiple outcomes and presenting those in an individual way to decision makers. I think that's a cop-out because all that's doing is saying, well, the health economists can't decide which the most important outcome is. Let the decision maker work it out. I don't think that's fair. The other analogy to public health is using this notion of capability. Amartya Sen was a philosopher stroke economist and talked about this notion of capability in terms of a capability to function. QALY is related to this idea of capability, but rather than maximising health, what you're saying is everybody should have a distribution of sufficient capability. Now, Sen was really clever. He didn't define what he meant by it. So then people had to then, if they wanted to define an outcome measure, they had to interpret it themselves. So what we're starting to see now is a suite of measures that are starting to try and measure this idea of capability. One's called IceCap, we've got the OxCap. Now, some of those might be relevant in the context of clinical genetics, but we're not ready to use them yet, and you'll see why. So, I'm going to finish, it'll take me a couple of minutes just to go through some options about what we might do. Option one is basically do nothing. So stay with the current UK GTN, who does a very good job. They look at what the cost impact is of a new genomic-based diagnostic, but don't go out there trying to kill yourself generating evidence of cost effectiveness. Just let the system work it out for themselves. I don't like that option. I'll be out of a job. Option two, health is viewed as a very specific public sector service within the UK, and appropriately so, because the market for health isn't like the market for other types of public sector services. But there's no reason why we might not take an approach like this, which the Green Book looks at non-health public sector services like education, and they do cost-benefit analyses. But if we did that for genomics, that would mean we're using a different evaluative framework compared with the one for other medicines. So then what's a decision maker going to do? Because the decision rule, i.e. how you say if something's good value for money, is different for cost-benefit analysis compared with cost-effectiveness. If we're looking at spending a whole healthcare budget, you're starting to compare your apples and pears again. Third option. Say, okay, let's use the EQ5D and the QALYs, but recognise that it's only going to work for a subset of services. The obvious example are examples where you're using genomic-based diagnostics in cancer genetics. Because quite often there's a very clear management strategy put in place. So you could say, okay, we're going to improve health because we've put some surveillance strategy or chemo prevention in place. But then that's again a cop-out because you're not dealing with all the rare disorders for which there are no treatments. Or you could use a modified framework and say, okay, let's work out which ones we think are going to be relevant for this modified framework. Let's pick a non-health outcome we think is important, capability to make an informed decision, measure it, and see what people think about that. Are they willing to give up some health to get some more of this ability to make an informed decision? This is a huge programme of work. I've got PhD students starting to think about it, but before we can use this, we need to have a lot of empirical evidence to support this way of moving forward. So, clinicians, funding bodies, health policymakers all know genomic medicine's a good thing. Alongside that, you're seeing cost-effectiveness analysis increasingly used. It's hard, but it's time to generate some empirical evidence, and that's what Wolf is starting to do. I'm just going to leave this slide without really talking through it very much. If nothing else happens, for a health economist to try and do anything, we need a national tariff for genomic-based diagnostic tests. Without that, we're not really going to get any further forward. I'll leave everything else on the slide, but that's my wish list is that top point. So thank you.